terms of a bit of background, the traditional surgical consultation involves a clinical assessment and an arrival at a diagnosis, a verbal discussion typically regarding these issues, consent to proceed with treatment, and finally implementation of that treatment. In terms of the goals of every visit, it should be really to educate the patient appropriately, to obtain informed consent, to provide successful treatment, and really optimize patient satisfaction. Ultimately, roadblocks can exist to achieving these goals. Poor communication techniques on behalf of the surgeon, time pressures in the busy clinic, the increasing complexity of operative procedures and having to really relate this to the patient can be quite difficult, and poor patient comprehension. So really, when we look at ourselves in the mirror, are we truly doing a good enough job in achieving these goals in our short clinical visits? Well, a recent paper published in the Medical Journal of Australia was published by a neurosurgery registrar and says these complaints based on the type of allegation and whether or not it involved informed consent. Then they looked at it based on a case-by-case basis in terms of the specialty involved. Essentially, they found 481 cases of alleged deficiencies involving informed consent were put forward to the health advisory. 57% of these cases, so more than half, actually involved surgeons. And when you break down the surgical complaints, really plastics, general surgery, orthopedic surgery, and ophthalmology accounted for 81% of cases. If you look at the actual informed consent cases, the number one allegation that was put forward was that a complication was not mentioned in any of the preoperative visits. Another paper published in JBJS looking at patient recall following applications at the time of consent and 6 weeks after the procedure really showed that there was a decline in the ability to recall information following the first postoperative visit. Looking at the foot and ankle group, this was a study published by Sherness and Colin in 2003, looking at the risks associated with forefoot surgery. Essentially, it involved two cohorts. It was prospectively done. There were 19 patients in each group, and in one group they had a verbal discussion, and the other group they had a verbal discussion with a visual aid. So really, 1 out of the 11 complications mentioned were recalled 12 weeks after the operative procedure. What possibly could be a solution? Looking at the Cochrane review of 86 studies, really decision aids have been shown to help patients improve their knowledge of possible options, to allow for more accurate expectations of benefits and harms, to reach choices that are really consistent with their own values, and to participate more in the decision-making process. Another review looking specifically at multimedia in medicine in general really showed that in 2/3 of studies, there is improved understanding of information with multimedia. So looking at this paper, really they summarize the state with media. Well, the rationale is it integrates video, audio, and animation to provide a richness of information. It can be adapted to various learning styles, and it can really optimize the communication channels that are available to provide effective information transfer. This was out of a learning journal, really looking at the theory behind it, but ultimately it just defines that there's a language form and a visual form that allows transfer of information, which ultimately gets integrated with your long-term memory and provides for better retention of information. This is just a quote from that article saying that if you can select, organize, and integrate information while participating with a multimedia by our group over the past 5 years. I really just read this study. It's actually Andre's study looking at the use of multimedia and to assist the informed consent process for knee arthroscopy. This was done at the Royal Melbourne. It was a randomized controlled trial involving knee arthroscopy patients. They basically identified 61 patients that were requiring knee arthroscopy, and in the pre-admission clinic, they allocated the patients randomly into 3 arms: a multimedia module group, a verbal consent group, and a pamphlet group. Information recall was then assessed using a questionnaire at the time of consent, at the time of surgery, and then finally 6 weeks following surgical intervention. The results were that recall was highest in the multimedia group at all 3 time points, and that retention of the information, as outlined in the darker gray bar, was really retained at each stage of that study. So in effect, they concluded that multimedia was an effective tool for providing and retention of information during the informed consent process. So how can we use this information in a clinical practice? I've had the fortune of being involved in reviewing a study that was done before I showed up in Melbourne, looking at the use of multimedia in the Victorian orthopedic foot and ankle clinic, which Andrew Beischer uses on a routine basis. Essentially, we looked at 56 patients, well, he looked at 56 patients requiring ankle ligament and then provided a standard verbal discussion. Following that surgical discussion, consent was obtained to participate in the study, and they then proceeded to complete a pre-module knowledge questionnaire. They then viewed the multimedia module and then completed the same questionnaire as well as a satisfaction survey. This is just an example of what the platform uses. It's a Flash program, Web 2.0 technology. Essentially, there's an index to the right. They can go back and forth between the slides. There's visual cues as to defining complications. There's animations involved looking at what outcome can be. And they also look at the actual operative procedure itself. In terms of this study, in the pre-module questionnaire, patients actually retained about 3/4 of their information, or at least got 75% of the questions correct, and it improved to 88% following use of the multimedia module. They ranked that they were quite happy with the amount of information and the understanding provided by this multimedia program, and 61% of patients actually considered the multimedia tool performed as well as the surgeon providing information. So in conclusion, really, we propose that multimedia technology can be used as an adjunct to the usual surgical consultation in a clinical setting to improve preoperative education, and it was well tolerated by all patients regardless of sex and age. Patient satisfaction was high. In terms of future applications, perhaps internet-based learning and obtaining informed consent through this way may be an avenue for the future. And with the use of smartphones and tablets, perhaps we can use this technology to allow for greater education, implementation, and monitoring of